Category 3 is the world of really bad disc problems on patients in the acute low back patient. These people usually have a lumbar disc involvement, along with subluxation, spinal degeneration, and some muscular imbalance. There are three primary causes of acute low back pain, and they're sometimes listed as myofascial, vertebrogenic, and discogenic, meaning that muscles and other soft tissues are involved, discs are involved, and the patient is pretty much always subluxated in the lumbar spine. And this is category 3 in SOT. And there's your three causes. What he did, if you read this carefully, he was happy until I removed the blocks, the category 3 blocks, and he showed to be a cat 3. So the block in cat 3 was correct. And then he took them out, and then he raised them up on the table. The mistake he made is he didn't finish his procedure. For each category, there's a set of procedures that you want to go through. You want to check everything, and he didn't check anything. He didn't find out what lumbar was adjusted. He didn't adjust it. He didn't do any traction to the disc. All he did was block. And this illustrates that category 3 blocking is, while it's the most popular part of SOT, you know, about 45% of all chiropractors worldwide claim they use SOT. They use category 3 blocks on hot low back patients because they know if they put the patient on the blocks, it reduces the pain. They feel better on the blocks. And I call this antalgic, passive antalgia. It's passive antalgia. You're putting the patient on blocks and you're pulling the nerve root and the disc away from each other. So the patient feels better. And they don't have to use their own muscles to create that antalgia. But he didn't finish. He never adjusted. And a big part of the problem is the lumbar subluxation. And a huge part of the problem is you have to rehab that disc. This guy didn't do anything. He just used the block. So I don't think the fact that the patient may have also been a category 2 was really the reason the other chiropractor got better results. I think it was the other chiropractor did more, and including adjusting. So I'm going to zip ahead here to where we were. Now, this guy Nelson, his name is Nelson DeCamp, and he's my SOT mentor. I respect him enormously in most respects as a great chiropractor. And I've had the amazing experience of watching him in action, and he's even helped me with my own patients. He's very, very smart chiropractor. If he was nearby, I'd go to him in a second. He's retired now. He's practiced for a super long time, over 50 years. And he's in his 80s, and he taught me most of what I know in SOT. We don't agree on everything, but we agree on an awful lot. And this last guy said, be sure to try the sacroiliac belt. I wouldn't try that on a category 3 patient personally. I'd rather use a lumbar belt. But this is a good example. Now, in every category, I've shown you that there's a flow of procedures. And that's true in Cat 3. And this flow in Cat 3 is extremely important. And frankly, I wouldn't deviate from this flow that I have here. You're going to block the patient category 3 style for about 10 minutes, at least 10 minutes. The longer they lay on the blocks, the better they feel. It pulls the nerve root and the disc apart in most cases. It substitutes for the antalgia that they came in with, so they don't have to use all that muscle effort for antalgia. And they just feel better on the blocks. Then we're going to go to something called step-out, turnout, which is a procedure to passively shorten the piriformis muscle. The piriformis is often involved in sciatica as a secondary cause of sciatica. And so we're going to check that out. And then we're going to traction the lumbar spine manually. If you have a mechanical traction table, like a Cox flexion distraction table, you can use that. Some people use computerized traction tables. That's fine too. Then you're going to figure out where the lumbar subluxation is. In the vast majority of category 3s, it's going to be L5, then second most common would be L4, then third most common would be L3. Sometimes it's more than one lumbar. You're going to analyze the lumbar spine carefully, and then you're going to adjust it. And there's two ways to adjust the lumbars. You already know side posture, although there is a unique SOT way of doing side posture. But I'm also going to accentuate orthopedic blocking, which in typical SOT style is done in a very safe way. It's acceptable by any patient on any visit, not just a Category 3 visit. But if you have to adjust a lumbar, orthopedic blocking is one way you can do it. It is a held tissue pull that's repeated several times, and it's very effective at helping the patient's lumbar spine function more normally. And then you're going to finish up by trying to make the brain less susceptible to the lumbar dysfunction. We're going to desensitize the motor and sensory homunculus of the low back with a cranial procedure called Basic 3. So we're going to go through each of these individually, and this is a very, very practical category because you're going to get some really hot low backs, and they can sort of scare you if you don't know what to do, and they can frustrate you. With Category 3 under your belt, you will almost never be worried. This is an algorithm that I found in that book you have on chiropractic diagnosis. Can't remember the guy's name right now who wrote it. You know what it is. Big book. There's different chapters on different parts of the spine. And I took this out of his book. So here comes the patient with low back pain of less than 4 weeks. You do an initial evaluation. There's no red flags, so you start care. If there are red flags, you're probably going to refer the patient out. But if you start care, let's say you start your care and you're looking for the patient to respond. So this is the what you do at the beginning. The red flags, of course, could be a fracture, cancer, infection, some sort of cauda equina. Maybe it's severe degeneration or a trauma to the low back caused cauda equina. Maybe the cauda equina is being caused by cancer or an infection or a fracture. So you will not be the first chiropractor to deal with this. You will get help. Maybe you don't have to see the patient as often. That would be your continuing care. So it's not just emergency care. Now it's corrective care. Okay? Let's say their limitations in motion, their pain tolerance is not lessening. Maybe they do have a red flag. Better recheck. If they don't really have a red flag, and let's say you referred them out, and there is no red flag indicator there, do they have any low back neurologic limb symptoms? Let's say they don't. You might want to do primarily, okay, it's not lower limb. It's maybe there's something wrong with the spine and the lumbar spine. Maybe you want to get some special studies. Guess what? There was a fracture, and you didn't realize it. Guess what? There was an infection. Well, that's a red flag again. If the special studies show nothing, you can continue on to treat this patient if they're willing to stay under your care. Maybe they're just taking a longer time to function normally. Now, going back to the neurologic limb symptoms, if they do have some lower extremity neurological positives, reflexes, sensory and motor, they have some nerve root compromise. If they do, maybe you need better imaging. If they do, certainly, you might find that out by EMG or somatosensory evoked potential studies, some special neurological procedures, and maybe they need more care. They might need surgery. They might need an epidural. And so if they don't need surgery or special imaging, continue on treating them. And if the epidural says they're okay, continue on separating them, treating them. If the epidural says no, they might have to have a surgical exploration. There's something going on. And very early in my practice, matter of fact, he was the first patient I ever saw when I opened up my first practice down in Atlanta. Severe low back pain, he'd come in and I would adjust him, and his pain was gone before he left. And the pain relief lasted about 4 hours, came back the next day, and I'd adjust him. Pain relief 4 hours, came back the next day. Same thing happened like 4 days in a row. He had a special x-ray taken. I don't even know the name of it. It showed a fractured facet in his lumbar spine that was swollen. And when I would adjust, the mechanical input blocked the pain. But it didn't last because he still had a fractured facet. I was doing drop table on him, and I don't know what I was adjusting. I don't remember. This was 1983. But that's what he had. I had a fractured facet, and they couldn't do surgery. Surgery wouldn't help. He just had to sort of wait for the thing to heal. And that was a case where better imaging showed the problem. Here's another algorithm. Adults with low back pain after discussion and consideration of special studies, they get treatment. They're either reaching their goals, support them. Now, I got this from a medical website, not a chiropractic. If they're reaching their goals, great. Continue seeing them. If they're not, you actually don't know what's wrong with them. And that's a philosophical issue in chiropractic that I've always had. I hear chiropractors to this day going around saying chiropractic cures everything. Well, that's not true. Chiropractic doesn't cure anything. The body heals itself if possible. What we do is we help it if we can. A very smart chiropractor I met years ago had this saying: take no credit and take no blame. Do your best on every patient. So treat every patient, every visit, like you're adjusting the king and the queen. Always do your best. Don't cheat. And we want the patient to get better. And sometimes they do, and most of the time they do. And of course that goes towards the value of chiropractic, but sometimes they don't really improve, even symptomatically. It doesn't mean you're doing anything wrong. It means that you don't know what's wrong with them. And that's a chiropractic issue, and that's a medical issue also. So try to get a correct chiropractic analysis. And this is a picture of category 3 blocking. The outermost blocks, you have a low block and a high block here. The short leg side in this picture is the right, the patient's lying prone, and that outermost block is aiming down at a 45-degree angle. It's on the short leg side in the prone position. The other block is the high block. It's placed underneath the patient's ASISs, and it's facing down at a 45 also. Most of the time, I mean at least 90% of the time, when you block a Cat 3 who has 10 out of 10 low back pain, within a minute or two, maybe 3, the degree of their low back pain has lessened dramatically. They can tell. Now, if it hasn't, you can move that low block around all the way from facing down at a 45 to facing up at a 45, somewhere in between there. The only thing Desjardins said was move the low block around till you get pain relief. If that doesn't work, move the high block around. So I'm showing 3 positions for the high block on the long leg side and 5 different positions for the low block. The low block possible positions would be 45 down, maybe 35 down, maybe straight in, maybe up at 20 degrees and up at 45 degrees. The vast majority of the time, though, the original blocking positions work really, really well. So some questions you might want to ask. Why does lying face down on category 3 blocks usually decrease the pain that the patient perceives. Now, neurologically, pain is a perception very much. It's how the brain translates dysfunction. So think about that. I'm not going to give you the answer right now, but think about why does this decrease pain? And here's a clue. I've actually already given you the answer. Now, Desjarnet's definition of a subluxation really always goes back to category 1, which is CSF flow dysfunction and stress on the dural system. What on earth does that have to do with a hot low back and a disc problem and dysfunction of the lumbar spine? Think about that also. The piriformis muscle runs from the anterior sacrum to the posterior greater trochanter. And when it contracts, it will slightly abduct the leg by pulling the trochanter medially, and it will externally rotate the leg. In the picture to the right, you can see the sciatic nerve exiting the greater sciatic foramen anterior to the piriformis muscle and inferior to the piriformis. Imagine that piriformis has lost its normal tone and it's sort of hanging down. And imagine that sciatic nerve already irritated from a bulging disc in the lumbar spine and a lumbar subluxation. You could actually have a triple crush syndrome by the time you get to the piriformis muscle. And in the left-handed picture, you can actually see I've colored the piriformis muscle there. It runs S to I and medial to lateral to do its thing. That is a frontal cut through the piriformis muscle on an MRI. And here's some other pictures of the piriformis. The picture on the right is the piriformis has actually lost normal tone. And it's actually lying on top now of the sciatic nerve. This is showing internal rotation where the piriformis bends, but imagine there's no internal rotation and the piriformis has just lost normal tone. According to some experts, the piriformis can be a source of sciatica or a secondary or even tertiary source of sciatica on some people, either because it's in spasm or because there's some sort of an inflammatory process going on in that area, or because it's lost normal tone. Nancy Molina is was a very good writer in Dynamic Chiropractic newspaper. It's an online journal now, but I used to get it in the mail, every 2 weeks or so. And she used to share her cases. This is a case history of an 80-year-old woman with abnormal gait, had sort of a very gradual onset over 2 years that originally started with acute right lower extremity numbness and tingling. Now it's a dull, deep ache right lower extremity. She had some diffuse weakness, right lower extremity, just wasn't as strong as the left in a variety of activities. Some loss of proprioception on the right. She had trouble determining what her right leg was doing. She had palpatory pain right SI joint and over the origin and insertion of the right piriformis. And there was decreased hip joint rotation in and out bilaterally. But that's not uncommon on people who are 80. Okay, so that's not a helpful finding. Her diagnosis ended up being primary sciatica or sciatic neuritis. It was not a radiculopathy or a radiculitis, meaning it didn't come from the spine. Her problem was almost totally piriformis. And she states that the most important distinction differentiating sciatic neuritis due to piriformis is there was no true neurological deficit. She didn't have terrible reflexes, totally blown out muscles, or real weird sensory findings. And she did have point tenderness over both ends of the piriformis. She thinks that the pressure on the nerve may derive not really from the muscle, but some sort of inflammatory process. And she thought that the patient had a piriformis spasm. So I think it varies from patient to patient, but piriformis is something that we always want to check on category 3s who come in with sciatica, which is a very common entering complaint. This was a case of the disc surgery did no good. Chiropractic care worked with pain-free within 10 visits. So the piriformis syndrome sure felt like a disc. And with chiropractic care, the piriformis acted more normal. I imagine maybe the hip joint was tested, the SI joint and the lumbar spine was adjusted, maybe the pelvis was adjusted, the piriformis was functioning better, and the patient got better. So this is a photograph of me doing a left-sided step-out turnout. So I'm sitting on a chair, and I'm abducting the patient's sciatic leg, in this case, the left leg. I'm holding the left leg in abduction on my lap, just so I don't have to bend over, but you can bend over and just hold the leg. I'm supporting the knee, or the leg above the knee. I'm abducting the leg, and I'm externally rotating the foot pretty much as far as I can. What this motion does is it mimics what the piriformis muscle does when it contracts. So I am doing what piriformis would do when it was contracted, but the patient's passive. And the idea here is to approximate the origin and insertion of the piriformis muscle, maybe to help reset GTOs in the tendons at the insertion and origin of the piriformis, and maybe to take some stress off the intrafusal muscle fibers in the muscle spindles of the piriformis muscle. What we do know is when the patient has sciatica, due at least partly to piriformis, before you do this, palpate down the sciatic nerve on the sciatic side, in the butt, in the upper, middle, and lower hamstrings. That's as far down as I go because there's no sciatic nerve below the knee. And see if it hurts. And if it does, even after the patient's been on the blocks for even 20 minutes, do step-out turnout and do it at least twice. The protocol is to hold it in this position for about 15 or 20 seconds, then to put the leg back on the table, let them rest a minute or two, and then do it again. And they can be on the blocks. The patient's usually on the blocks when I do this. But it doesn't matter. It'll work equally well on or off the blocks. And then after 2 or 3 attempts at doing step-out turnout, repalpate that sciatic nerve going down the leg. If it's less painful to deep palpation now, they have some degree of what's commonly called a piriformis syndrome, which is usually treated medically with an anesthetic or an anti-inflammatory injection or surgery. So I have never had a patient who had piriformis surgery, but I know they're out there. And what they usually do in the surgery, as I'll show you some research here, or you can read it for yourself, they usually cut part of the piriformis muscle away. So there's this chart. It's for the step-out turnout chart. And basically what this chart shows you is that if step-out turnout helps, you've either got a piriformis problem or a hip joint problem. And I've never seen it be hip joint for sciatica. I'm sure it's possible. What I've seen is piriformis. So you do step-out turnout a couple of times and it helps. That's great. If it doesn't help or it gets worse, it's not piriformis. It could be anything from a subluxation to some sort of a disc issue. On this chart, we'll come back to this chart later. There's something called cervical palpation findings. This is important when we try to palpate the neck and get a lumbar listing by noting palpatory pain in the neck. And We're going to do this next week, and this is quite amazing. This enables you to get a lumbar listing almost immediately and act on it. Go down there and adjust, and then come back and your cervicals feel better. And also listed here is prognosis. So if all you have is piriformis, the prognosis is good. If you got a disc, the prognosis is slow and guarded. And this is important with insurance companies and attorneys and patients. They need to know they have a disc problem. This is a soft tissue issue. It takes a while to get better, so they have to have some patience, but you're going to do your best. And if you use the entire SOT protocol, wow, you've got a lot of tools in your toolbox to deal with that Cat 3 patient. This is some research. You can read it on your own. You can read that on your own. You can read that on your own. And I'm going to start with this slide in part 2 that we'll cover next week.